We have an awesome presenter. Yaifeh Chafeh is here with us, and she is a psychiatric nurse practitioner with 4 years of experience specializing in the treatment of substance use disorders. She's been a nurse for 13 years and has a diverse clinical background that includes neuro ICU, interventional radiology, adolescent psychiatric nursing, stroke care, and home-based care. Her practice is grounded in a strong foundation in neuroscience and acute care with an emphasis on evidence-based and standardized approaches to psychiatric assessment and treatment. She is particularly interested in patient-centered care for complex psychiatric and substance use presentations and remains committed to a continuous learning and professional growth in an evolving field. Now, this is part one of a two-part CE. Today, we're going to cover part one of cannabis and psychedelics. We're going to rely heavily on the cannabis part for this first part one, and then we'll cover psychedelics a little more in depth in the second half. But I'm going to turn the time over to Yafe now. The time is yours, Yafe.
Awesome. Thank you so much, Joseph, for that introduction. I won't waste any more time, but I want to thank you all for being here. Thank you, Joseph, for inviting me to speak on behalf of UHS. And thank you, everyone, for your time today with me, spending the next hour. So let me go ahead and share my screen so we can go ahead and get started. All right, so cannabis. We're just going to be going over understanding effects, risk, abuse, and treatment in a legal age. So some of the objectives we're going to be going over, we're going to identify short-term and long-term physical and mental effects of cannabis. We're going to analyze how legal status intersects with the risk of cannabis abuse. And we'll go over evaluating current treatment approaches and research on interventions for problematic cannabis abuse. So definitions, so cannabis, I'm also referring to THC and CBD. So there are two aspects of it. Mostly we'll be going over THC. And then the psychedelics, we'll be going over part two. Substance use disorder will refer to the psychedelics, and then CUD or cannabis use disorder will be in reference of cannabis abuse. So some of the trends that we're looking at um, over the years in cannabis and psychedelic use, we see that since around 2012, 2013, we see how it's trending upward over the last 10 years. So this not only shows, how prevalent it was, but also how many more people are using it over the last few years. And this can also be, people are doing it more in school, doing it more at home. It's all about, where people are accessing it, what they're hearing about the substances. So this is another reason why I wanted to go over this subject with you guys. Okay, so just a little bit more. We're at the historic highs for cannabis and hallucinogens. They're rising sharply over, especially the last 5 years, have increased even more drastically since 10 years ago. And that's due to normalization, like I mentioned earlier. Not only are we seeing an increase in trend, but we're also seeing an increase in the concentration of the substance. So we're hearing that the cannabis that you are getting now is a lot stronger than it was, or it's not like it was back, when you were probably younger or back in the day. Okay, so let's get into cannabis. So the mechanism of cannabis. So like I mentioned, we have two specific um, parts of cannabis. So we have THC, which activates the CB1 receptors. And this is the psychoactive part of it. And this is classified as a Schedule 1 according to the FDA or the DEA. Okay. So meaning Schedule 1, meaning that it's not considered of any medical benefit and it's simply for recreational use. And then we have the second most most common part of cannabis, which is cannabinoids or CBD. And this is where the CB2 receptors, and this is where you'll see this probably sold as CBD. It's non-toxic and Schedule 2. So it's still a controlled substance, but they're not constituting it at, there is some medical benefit towards it. So that's what Schedule 2 means. This is where you'll see maybe the creams or the topical solutions or those kinds of things that are CBD. So there is a difference between CBD and THC. Okay. And here you have a little bit of a picture of CB1. That's mainly activated in the brain and the central nervous system. Okay. And here we see that's our psychoactive component, right? So we'll see a lot of psychoactivity that's acted on the brain and the central nervous system. That's where it affects. And then the CB2 receptors are mainly through the peripheral organs, immune cells, and GI. Okay, so like your stomach or, like the liver, just your peripheral organs. Okay, and that's where we see sometimes the medical benefit. This is how this was pushed for a medical indication. Okay, so some short-term effects of cannabis use. Okay, so after using it, soon you'll feel a little bit of euphoria, you'll feel relaxed. You could also have some impaired memory or attention, not really remembering everything, not really, paying attention to acute details as if you were not using altered perception, meaning, you could see something, you thought it was something else. So just your perception is just off. Motor impairment, maybe you're a little clumsy, you're dropping things, you're moving a little bit slower. Okay. And same thing goes with impaired attention, memory, and coordination. We also can get some anxiety and some paranoia with the short term effects. Okay, meaning you're feeling a little bit on edge, you feel like someone's watching over your shoulder, so things like that. Your heart's going to race a little bit with tachycardia, and then the psychotic like symptoms, which ties into the paranoia. And then we have the short term risk. Okay, so same thing we have, which is maybe getting anxiety or a panic attack. Okay, this is from shortly after using the marijuana or cannabis. And most likely, this would be the THC component of it. Okay, not necessarily the CBD, but because it's psychoactive, THC, this is most likely relative to the THC component. And then we also have acute psychosis, like I mentioned before, the paranoia, where you feel like someone's watching over your shoulder, you just don't feel safe. And then we also have a driving impairment, and that can come into with your um, your motor function, which is impaired, your impaired concentration. All of those things come into play with how you drive, which can pose a risk and make you an unsafe driver with acute use of cannabis. And then we have long-term effects of cannabis use. So we have ongoing cognitive impairment, okay, cannabis use disorder. So long-term, you're now classified as a use disorder. And then you can also, of course, with any smoking, respiratory issues. And then we also have hyperemesis syndrome, which I'll get into that. And then we also have long-term effects of affecting your mood, affecting your anxiety, which is a lot of people, like to say that the opposite at first, right? I felt better or I felt less anxious, but come to see that over years of using, a long-term effect of it is changing your mood and possibly exacerbating anxiety. Okay. And then we have mental health risks that are associated with cannabis use. So we have the increase of psychosis, and this is mostly commonly found with high potency THC, and which I showed in the previous slides before. Potency has increased drastically over the last 5 years. It's not the same marijuana or cannabis that you would have gotten 10 years ago. Then you also have, of course, cannabis use disorder associated as a diagnosis because of your use, altered neural development in youth. So young people who are young, their brains are not always, their brains are not developed. Okay, so this is just scientifically true, right? Our brain is still developing. So if you introduce something like cannabis or THC, which is psychoactive, which has effects on the nervous system and your brain, you're running the risk of altered neural development. Okay. And then we have higher risk of psychosis in predisposed individuals. This could mean people that predisposed individuals are people that were mainly possibly had an episode of psychosis before smoking, and now you are having a higher risk of having psychosis again, or maybe a family history of someone who has had psychosis in their past. Unfortunately, it can be genetic, so you're running into diagnoses or people or family members who have had a diagnosis of things like schizophrenia, schizoaffective disorder, things like that. So you are predisposed if that is something that is in your history. So some more risks that we're going to talk about with cannabis use disorder or cannabis use. So the first one here is really important: motor vehicle crash risk. So they are learning that motor vehicle accidents are also prone because of cannabis use. 2 to 3 times more likely that you'll see that they're seeing motor vehicle accidents caused by driving under the influence of cannabis and not necessarily alcohol. This is something that they're working on with because it's kind of hard to diagnose. Yes, we can test your urine and see that there is cannabis in your system, but because it's not quantified as if, such as alcohol acutely, the levels, they have not came up with a system yet to actually coordinate or directly relate the accident with the cannabis use disorder. But I guarantee you guys, in the next 5 years, maybe sooner, that will be something that police will be enforcing as well. And then, of course, we have addiction. So we see about 1 in 10 people do have an addictively use cannabis. And then we have anxiety, depression, and psychosis, mental health disorders that are risk of cannabis use. Um, and then we have cardiovascular health, your heart health. I mentioned earlier, your heart will increase with short-term use of marijuana. So this can also induce hypotension, which is your heart rate, your blood pressure dropping, excuse me. And also because of the high heart rate, your heart is beating really fast. You're requiring a lot more demand on the heart. If your heart is working harder than what it's used to or what it can handle, then you have risk of running into um, a heart attack. Okay, and we see a relation growing with testicular cancer and infertility. So for men and women, they are affected in these ways. And now we'll get into the benefits, the other side of cannabis, right? So why is cannabis medically prescribed? So this is how we'll get into the other side of cannabis. Yes, we have the effects that are associated, good and bad, but we have the medical use that has been shown with cannabis. And the most common ones are chronic pain, epilepsy, and nausea. So you'll see this with people like with cancer. They might have a marijuana card or cannabis card to go ahead and treat their chronic pain. Or someone with a seizure disorder or someone with chronic nausea related to their chemotherapy. Okay. So high potent products of marijuana. So now we're looking at things like concentrates, dabs, and vapes. So if the marijuana is coming in these forms, it's usually a even higher potent product. Okay, and that what are we running the risk in? We're running that risk of um, higher acute psychosis with the higher concentration. So I wanted to give a timeline of smoking it versus edibles. A lot of people, feel like edibles is a little bit less volatile or less taboo than actually smoking it. But you'll see here smoking, the onset, it happens in minutes. You'll have a peak in about 10 to 30 minutes and it lasts about 2 to 4 hours. If you're taking edibles, due to onset, it takes longer to feel the effect, 1 to 3 hours. The peak is in 2 to 4 hours, and your duration is lasting up to 8 hours, even more. Okay, so people take edibles that go to sleep at night, may help them with sleep, but guess what? In the morning, you could possibly still have effects of marijuana when you're waking up in the morning, okay? Because of how long it can stay in your system. So this is another one I wanted to talk about, which is synthetic cannabis. So this is another kind of cannabis that kind of you'll see in smoke shops or that is used to mimic THC. So this is a designer drug intended to mimic THC. It's also known as K2, Spice, Black Mamba, Joker, Scooby Snacks, Blaze, Chronic, Mr. Nice Guy, and this is usually disguised as potpourri or herbal incense. Okay, hundreds of different kinds of synthetic cannabinoids are sold as legal alternatives to cannabis. And you'll see these in like smoke shops or all those other kinds of shops where it's not gonna be seen at TJ Maxx or Walmart, but you'll see it in more like gas stations maybe or smoke shops. Okay, and then we have yes, and this is a spray or this is a spray or a mix that is sprayed onto a leaf or a plant product. Okay, and that's how they can put it into something to smoke, or even something to vape. Okay, so really it's a chemical that you're smoking and not the plant. And it has a stronger affinity than THC. So not only does it mimic THC, but it's a stronger affinity and more volatile. And it's not detected on standard UDSs. So if you're suspecting someone is high or under the influence of cannabis, a simple cannabinoid UDS won't detect it, and you would have to request. It is detected on a special request if you send it out to the lab. So, cardinal acute symptoms of using something like a synthetic cannabinoid, you'll see someone with red eyes. Of course, there are other ones, but these are the cardinal symptoms. You'll see someone with red eyes, impaired cognition. Maybe they're not talking in clear sentences or wandering off. And you'll see heart changes. Patient may be feeling it too, but because of impaired cognition, they can't really tell you what's going on. So if you place someone on an EKG, you'll see there's a lot of arrhythmias going on. Then we have acute symptoms. So this includes tachycardia, elevated blood pressure, unconsciousness, tremors, even seizures, vomiting, hallucinations, agitation, anxiety, pallor or sweating, sweaty hands or just clammy skin, and then numbness and even tingling to the extremities. Okay, so long term, someone who's using this chronically, a little bit more than just a few hours ago, more than we're talking about a few days to a few months to a few years, they can run into chronic symptoms such as agitation, okay, anxiety, seizures, a stroke, coma, even, and then we're looking at acute kidney injury. So, our kidneys are directly affected with this chemical, and it could require hospitalization or even dialysis, to help keep those kidneys functioning properly. And we all know dialysis is something you have to, it's like your kidneys. a machine that's working for you as your kidneys. So it's something you have to go to 3 times a week just to keep your kidneys and removing the toxins from your body. And then, of course, we also have death by heart attack or organ failure. So I wanted to get into something that I mentioned earlier, which is cannabis hyperemesis syndrome. Uh, Sorry, I think I uploaded the wrong one and I don't have all the special effects and all that stuff. But I still have all the information. Okay, so cannabis hyperemesis syndrome or CHS, this is something that you guys can also look into if you want some more information on it, but the cause is not exactly known. But they are suspecting that this is because of overstimulation of the cannabinoid receptors in the body. So receptors in the bodies are constantly being stimulated by cannabis use. All right, and this is we're talking about 10 to 12 years of chronic use. So someone from their childhood all the way to their adulthood that's been using it chronically, and they've been using it at least once a week. So this doesn't have to be every day, 3 times a day. This is just up to once a week using it chronically. Okay, someone with this syndrome is going to come in and they said only hot showers. They've been taking a lot of hot showers because that's what's relieving their symptoms. Okay. And so some of the symptoms that I am referring to are intense abdominal pain. You can see that over here. So really bad cramping, persistent nausea, always feel like you want to vomit, loss of appetite, don't want to eat, and then we have repeated vomiting. So the treatment to this, okay, is quitting. Just plain and simple. I know easier said than done, but the for cannabis hyperemesis syndrome, the treatment that they're going to tell you, the cure is to stop. Of course, when you stop, the symptoms are not going to abate over the next few hours. They say over about the next few weeks from the last time you use. That's when you should see a resolution in symptoms, and then over time they should fade away and completely go away. So there are some medications with varying efficacy that are believed to target areas that produce or invoke emesis or vomiting. Okay. These are not FDA approved for a cure to treat, but they're only to treat the symptoms, the symptomology. Okay. So we know what our etiology is, which is overuse of cannabis, chronic use of cannabis, which is causing this hyperemesis. So these medications that I will get into um, will go over treating the symptoms and not actually curing it. So if we're giving you these medications, but you're still smoking marijuana, you're kind of just having a double-edged sword here. We're not really gonna take care of anything, and you're running into complications of medicate chronic using the medications. So some of the medications some people might use benzodiazepines like Ativan, lorazepam or Valium, diazepam for short-term uses, just to, in the acute moment. So this is only about a few days. We're talking about less than a week. Okay, anything more than that or chronic use of that, then you're running into more complicated situation. Then we have antiemetics. So we're talking about ondansetron or metoclopramide, sorry. And these address the vomiting and nausea. And then we have antiepileptics, otherwise known as Keppra, there's no, and like I mentioned before, these are believed to address areas in the body that induce or provoke emesis. Okay. And then we have antipsychotics, we have capsaicin cream, and this is to mimic those hot showers they're always in. So just to prevent all of the maybe scalding to their body from hot water all the time on their skin. They can use something as opposed to being in the hot shower all the time, wasting the hot water, wasting the water bill, right? And then we have TCAs, which are also classified as antidepressants that is targeted possibly can help with symptoms, anticholinergics. And then we get into opioids. Opioids we know, is a pain medication. Patient is having chronic pain, really sharp pain to their stomach. Um, a provider may feel like opioids is indicated, but research shows that this worsens symptoms, okay, and it can probably make the nausea and vomiting worse. Okay, so we
Mm.
want to keep any other one of these just to address the symptoms, to help with symptom relief. And also, we want to remember that if the patient is still smoking, you know, I believe we know some of the long-term effects with these medications. Okay, like antipsychotics, it can cause metabolic syndrome. Okay, now we got to look at their blood sugar and weight gain possibilities. Okay, and antiemetics, gastric slowing. We don't want to cause a paralytic ileus. Okay, and TCAs, we don't want to cause QT prolongation. Okay, so we want to really make sure that we're treating the symptoms and the patient is doing their work by abstaining from cannabis use. So here we have a pretty relevant map on cannabis legalization within the US. Okay, so the dark ones is where we have legal, marijuana is legal. Okay, I think you guys said you're in Utah. I'm not sure. Don't hate me. I'm not the best at geography. But yeah, so we have the dark green is fully legal, fully legal. And then we have the green ones, we have only medical use. All right. And then the gray ones are considered there's no real legal use for marijuana. They may have products like CBD, but marijuana or cannabis, THC is not legal, considered legal in these states. Okay, but you may see, like I mentioned, you may see some products like CBD, which is not a psychoactive substance and can be more of medical indication. Okay, but marijuana in whole will not be legal in the great states. And then we have our impact on use rates. Okay, so here we see up here on the top ages from 18 to 25 years old. We see in red in around 2013 of how many people were using it. And then we see over in 2022 in the same group, use jumps. We see in Alaska how much it jumps. It almost doubles. Okay, and then we also see Colorado, Oregon. These are some states that show some significant jump in use. And like I mentioned earlier, look at 1995, the potency of marijuana. Okay, 3%. Now we're talking about 5 times more in 2024, as of 2024, much more potent. So now like I mentioned, we're running into those risks of acute intoxication, psychosis, anxiety, panic attacks, and things like that. So we've had an increase in post legalization and mainly adults. Okay, and then we have but I do suspect that will change more over the years if children or youth are going the rate that they are going. That we're going to see an increase in youth as well with marijuana. And then adolescent use, mixed findings, like I mentioned, but I do suspect over the next few years, we'll see that it's increased in children or youth. And then we're also seeing an increase in ER visits related to acute intoxication. And that means the acute presentation of their use, which could mean the psychosis, the anxiety attacks, or even motor vehicle accidents. Okay. And here's some more visuals for you guys. We see in Maryland the ER visits that were recorded. So we see that we started around 400 people, and this was showing over a span of 10 years. Sorry, it was cut off. But we see over the last 5 to 3 years how high it's jumped up. It's doubled. Okay, and this is just in marijuana alone. And then over here we have the daily use, same thing in adults. Okay. So like I mentioned earlier, we're not really seeing it in youth, but we there has been recorded a higher rate in adults. So 35 to 50 years old, we have seen from 2013 for about 10 years, 168% increase. We're still seeing it in children in the youth, less than 30 years old. And that could possibly be because, there are a lot of new drugs on the scene. A lot of older people are more familiar with cannabis and a little bit more skeptical about the newer drugs that people are seeing. So that could also possibly, um, um, be why we're seeing an increase in adults over the last 10 years versus youth, although we do still see an increase in youth, 76% over the last 10 years. And then we're seeing how it's affected the globalization, how it's expected globalization as far as marketing with cannabis products. So we do see a growth in marketing, in trends, and all over North America with cannabis use. So we have public health outcomes, public health concerns that arise with cannabis use disorder. We have more diagnoses of cannabis use disorder, um, DUIs related to marijuana use, and even poison control calls. Edibles. Why do you think they're saying edibles? Because it lasts longer in your system. Okay. Because it's lasting longer, people are more prone to having those side effects. And it's hard to shake off that paranoia or psychosis in the next 2 to 3 hours. You're talking about this could last for a few hours, 4 to 8 hours. So now we're talking about, getting someone in to intervene, to medically intervene. Okay, so let's get into use disorder and treatment. So like I mentioned before, there are no FDA approved medications to treat cannabis use disorder. Behavioral therapies are the first line treatment. So it's not a medication, but it is a treatment. So we want to change the behavior. So behavioral interventions, they include CBT, cognitive behavioral therapy, or motivational enhancement therapy, contingency management. And this is something you don't see a lot, but it is out there. Contingency management is where they're possibly giving you an incentive to quit using the drug. So it's not only in cannabis, but it's also in other substances like heroin, methamphetamines, other things like that. Some states, cities, or use disorder centers will have a contingency management process in place. Um, yeah, and it's shown to be helpful. Okay, so they might reward you with like a gift card for being 1 month sober, and they do that. That's how they incentivize you to stop using. And then also mindfulness-based relapse prevention. So all about changing the behavior. Okay. So we have emerging pharmacotherapies. Um, So these are medications, like I mentioned, they're not FDA approved, but these are popping up with research showing that it's showing some efficacy in helping people abstain from using and it helps with the cravings. So we have the first one, N-acetylcysteine, or otherwise it's NAC, which is pretty much it's a vitamin or a mineral, I believe, and it does show mixed evidence. This is something that I use if you come to me with really bad cravings, you're having troubles from stopping to use it. I'm going to use it versus give you nothing. Okay, virtually no side effects with this medication. So it is something that I use pretty frequently. And it also has been shown, mixed evidence again, that it can reverse some of the effects, long-term effects that have been shown caused by the cannabis use disorder. Okay. And then we have gabapentin. This is just for withdrawal symptoms. So if you're in the acute phase. And then we have CBT. Remember CBD, remember this is the non-psychoactive portion of cannabis. So there, maybe if it's something you're smoking for pain, maybe going and downgrading to just a cream, a CBD oil. We're not looking for the psychoactive substance part of it, and more of just addressing the physical part of it. And then topiramate. This reduces use but is poorly tolerated. So this is another one that I like to use as well. And it is true, it can be poorly tolerated. So this is something I have to really use slowly. Something like gabapentin, you can jump up in doses as tolerated within a few days. But topiramate, you have to wait weeks before you jump up in the dose. So patient may see, I don't feel anything, or they don't have any efficacy, but that's something you can't jump up on. If you do jump up too quickly, they are more prone to having severe brain fog, which is something that's pretty commonly reported if it's titrated too high. So something like, oh, I don't remember where I put my keys. I don't remember where I ate for breakfast, or I know this person, but I can't seem to remember their name. So it can get really severe based off the person. And if that happens, just slow down the titration or come down on the dose. So let's focus on the cannabis side. So harm reduction and patient education. Why are we telling you to stop smoking? Okay. Cannabis can trigger acute psychosis, especially in high THC products. Okay. Also, symptoms can mimic things like schizophrenia. Schizophrenia is a lifelong diagnosis, something that is treated. This is not something that can spontaneously go away. It's treated with antipsychotics, and it's imperative that that patient be on it. So, worst thing is using cannabis and you being diagnosed with something like schizophrenia, which can be debilitating, okay, for your quality of life. And then we have treatment is supportive. Antipsychotics are there if needed, and then abstinence is key to prevention.
Sorry, I just had a Zoom open.
Let's go ahead and go over a case study for a patient that comes in with cannabis use. I'm not going to say cannabis use disorder, but someone who is using cannabis. Okay, so we have a 22-year-old male who comes in, no significant history, so we don't know about his family history. Never came to the ER before for an episode of psychosis or a panic attack. And he comes in, he's saying, people are watching, I'm not safe. Okay, so looking in, we see that the patient was using high potent marijuana, um, acute onset of paranoia, psychosis, and agitation. Okay, this is how the patient is presenting. All right, so our objective is pretty much he's in active psychosis, has labile mood, impaired cognition, and we did a urine drug screen, came back positive for THC, and we do see his heart rate, EKG coming back at normal. Then we have our assessment. So we have our differential diagnoses that are going to be considered. Okay, so we have substance-induced psychotic disorder, schizophrenia, brief psychotic disorder, bipolar disorder, manic with psychosis. And now we want to talk about our plan. What's our plan for this patient? Okay, so you first want to get them in a safe, calming environment. Reduce stimuli, make sure that, they're safe for themselves. There's no risk for harm to others or to themselves. So we want to decrease stimulation, put them in a room, low lights, talk to them, make sure that, let them know that they're safe and everything is okay. Medications include benzodiazepines for the agitation. Again, this is something that's short term. Maybe you shouldn't need it for more than a few days. Antipsychotics for severe psychosis. So now we're talking about what's severe versus how do you know what's severe? So patients coming in, they feel like someone's watching them, but they're calm. They're not showing any physical symptoms or physical signs of agitation or aggression. Okay. So, we just destimulate this patient, hopefully that over the next few days with a benzodiazepine in their system, they can detox from the cannabis safely. If their psychosis is severe to the point where they're hearing commanding hallucinations, this patient is a danger to themselves or danger to others, then we want to introduce antipsychotics into their plan. Okay. And we want to monitor for improvement over the next 3 days. How do we know about whether we're going to diagnose this patient with schizophrenia versus brief psychotic disorder or substance induced psychotic disorder? So, this is all about timing. If over the next 3 days we're seeing this patient is getting better, yes, then we can, safely say for right now that this was directly related to their substance use. Now, if they come back to us in a month or even a year later saying that, they had a psychotic episode, this could now we're looking into, okay, now we're looking into an actual disorder. Now we probably need to diagnose this person with schizoaffective disorder, schizophrenia, something along that lines, and look into long-term treatment to prevent further psychotic episodes down the line. Okay. And that is all. Those are my references, and that's all I have for cannabis use for today, guys. And then I'll go ahead and take some questions.
Let's go ahead and take some questions. I want to kind of scroll back up through the chat here. I know we had a lot of good questions come in, and I apologize that we didn't jump in immediately. I just didn't want to interrupt. We were at such a great pace. But I think our first question was, does the use of cannabis exacerbate the effects or the presentation of dementia?
Great question. So for dementia, they have not directly related the two. Dementia is more of um, so we're talking about dementia versus delirium, right? Delirium is acute. Dementia is something that, um, is chronic over the years and can look like, can turn into something like um, Parkinson's or something like that, a neurocognitive disorder. They have not related the two, but that is a great question. I didn't see any of that, but uh, I would lean more towards psychosis as a direct relation to cannabis use disorder. And because you're seeing dementia more in the older population, you don't really see psychosis. You're seeing more of confusion or impaired cognition. So I think that's what kind of differentiates the two when you're seeing a neurocognitive um, biological disorder versus cannabis use disorder effects.
Great. We also had a question from Fabiola. If you, she's kind of clarifying here, did you say that short-term risks are associated with THC, not CBD? Maybe you could
So
clarify.
yes, short-term risk are those short-term risks were related to THC. So CBD, yes, can have some. All right. So, but because you don't have that psychoactive portion of marijuana, the THC, you're not going to really get those. But I have had some clients say that, I like to relate it to decaffeinated coffee. You can't take 100% caffeine out of coffee. There's always going to be a little bit. So you can never completely separate the two, especially if that's what they come in. So as much as extraction as you can do, you're never going to completely get rid of 100% THC in a CBD product. So that's usually how I like to think of it as when you're drinking decaffeinated coffee, there's some caffeine in it, but not enough to really affect you as if it were caffeinated. So that's how I like to relay that difference.
Great. Another question was, will the brain impairment last even if you quit the THC? And then a follow-up question, will the brain development, or I think they're referring to disorders, will they stop if they quit using it?
So the brain development. So now we're talking about youth, someone in a developing brain. Okay. So someone in a developing brain, it's just like trauma. Okay. Something that you're inserting into the brain as they're growing. That's what they're going to kind of go experience as an older adult. That's going to change their perception, right? Into certain situations growing up. as a child or a youth with a developing brain and you introduce something like cannabis, where you can have at risk with anxiety, impaired cognition, impaired motor skills, psychosis. So things like that, you are predisposing that youth to that. Over the years, as an adult, can this eventually go away? I would say you're depending on the potency of the cannabis. Okay, that's about your best chance of the patient or the person not experiencing anything. And as you get older, yes, with cognitive behavioral therapy and all of those behavioral interventions, the brain has a great capability, especially as a younger person, to regenerate neuroplasticity. Okay, so that's another great thing about the younger brain. So the earlier they stop, the better chances they have of avoiding long-term effects like the anxiety, psychosis, and impaired cognition.
Another question was, how do we know what high potency THC means? Or I think they're asking like, how will we define what high potency THC is?
High potency. So there, when you if you go to a cannabis dispensary, they might tell you this is really really strong, and I think that would be a good indicator, that's really high potency versus something that's, something that they're classifying as this is low grade. I can't tell you exactly because there's no content like in alcohol. There's no percentage that they're really advertising. Okay, so maybe just by talking to the person in the dispensary, because I'm sure they know a lot about the products they're selling and how they're growing their products. That's also an indicator on how potent the marijuana can be.
So, someone else had asked, I am wondering how cannabis affects a developing fetus.
Great question. So there have been studies in marijuana in pregnant women. I didn't really get into how it affects the fetus, but because you would think, marijuana is used to treat pregnant women with, I'm going to say marijuana is used to treat hyperemesis or someone who's constantly vomiting in like people with chemotherapy. Okay, and I understand that it's kind of contradicting as far as marijuana can cause a hyperemesis as well as treat it. But in a pregnant woman, someone who's coming in for marijuana, I mean, for hyperemesis or constant vomiting, they can't keep anything down. There have been studies showing that yes, they gave marijuana and it did help, but because of the unknown effects of the fetus, it wasn't something that was continued in the study. And we all know that it's affecting your brain. Okay, THC affects neurodevelopment. So I'm sure it's the same, it's going to affect the child, the unborn fetus, the same way it would affect a child using a child that could possibly use marijuana.
Great. Another comment or question was, di they use the word differential. Maybe this is differences between the diagnosis of hyperemesis and bulimia or anorexia. Like, is there a way that you kind of weigh the two when someone says, "Oh, I mean, I'm experiencing these symptoms." How do you determine whether it's hyperemesis or bulimia, anorexia?
Yeah, so definitely you're going to have a differential diagnosis. Um, when someone comes with severe vomiting, you're going to suspect bulimia, anorexia, and then you're going to suspect THC use or chronic THC use. So hyperemesis syndrome, remember the diagnostic factors is chronic use of marijuana, 10 to 12 years. Okay. And then we also see that they have marijuana in their system. Okay. So we want to do a good H&P and really ask them. And we want to see all of the contributing factors that differentiate. So a good differentiating factor would be whether their UDS is positive for THC or not, and seeing how long they've been using it for, if it is positive.
Great. Another individual had asked, I think this is Anna, who asked, she thought medical use was legal in Georgia. I think Spencer jumped in the chat and said that he thought the map did say that some medical use was permissible in some of the states, even though it wasn't marked. So yeah, maybe just make sure, whatever state you're in, that you're familiar with that,
With
um,
your laws, exactly.
with your laws exactly. Yeah,
That's your best source.
I would say so. Also, Roseanne's got a really good question here. She's asking, are tinctures considered edible?
Tinctures considered edible. I wouldn't consider them edibles. I would consider them concentrates. Yeah, so you're putting a drop of oil under the tongue. I would consider them, or even if you're mixing it. So, say you're taking a tincture and you're maybe mixing it in butter. I've had some people mix it in their butter or put a drop in their coffee. Now you're just mixing it with food, but it's not coming to you as an edible. This is something you're just creating and ingesting it in a different way. But all in all, it's a concentrate.
Got it. Another question was, I always get people or clients saying cannabis is a plant and it's not harmful. It calms them down and relaxes them. Most of them argue that smoking pot is helpful for them because they can think better and are more aware, etc. The argument is always that it's not addictive and it's way better or safer than alcohol. So, what are your thoughts on this, and how do you handle these thoughts or these statements?
So, yes, of course, working in substance use for so long, I have patients that forget to mention, oh, yeah, I also use marijuana. But they have to understand that is something that is considered harmful to the body. And as I mentioned earlier in the slides, that there are short-term risks and long-term risks that are associated with use. Now, this person per se may not have experienced those negative effects, and they just haven't experienced that. Okay, um, that would be one of the lower numbers that don't have any long-term effects. I'm not saying that in the future they won't, but at the same time, um, mentioning all of those things, and I also like to mention to my patients, what came first, the chicken or the egg? Did you have problems with your anxiety before, marijuana, and marijuana is just suppressing it temporarily? Okay, or anything in that situation. All right, so you may think that this is helping you, but then in the end, when you try to stop using it, your symptoms are exacerbated. Okay, so you could have had this situation the whole time, or how old were you when you started? Okay, we also talked about neurodevelopment changes and effects on the brain. So now you may not have had an issue with anxiety or panic attacks or any kind of issue with like that before, but because you trained your brain to use marijuana as something that was calming or could have helped you in any short matter, maybe dealing with trauma or dealing with being out in public, which is something you would have had anxiety with dealing with, but now marijuana has been masking those symptoms. And now when you try to come off of it, you're having trouble, your symptoms are exacerbated, you're having changes in your cognition. So all of those things come into play. Um, you know, yes, it's unfortunate that people do see this as something that it's not a problem, but research shows, otherwise, that it is a problem more than not. They may slide under the radar, and the few percent that will, but let them try to come off of it, then we'll see symptoms exacerbated. So is this something they're going to be on for the rest of their lives, or are we going to try to address the symptom that was always there to begin with without marijuana?
One other question was, is gabapentin promising for just cannabis withdrawal, or what about other meds like Suboxone?
And what are we referring to in treating cannabis, or just symptoms and withdrawal in general? So there's no indication to use Suboxone. So we know Suboxone is also a controlled substance that works on new receptors, opioid receptors, not necessarily cannabinoidal receptors. So two different products we're talking about addressing two different things.
Got it. One other question was here, they're referring to a case study, it sounds like. Is it possible the cannabis that they've consumed is somehow tainted with other chemicals?
So that's another great question. So it is very possible. You know, you never know really how the marijuana was grown or produced or manufactured. Um, that's another reason why people run the risk of more severe side effects like psychosis, anxiety, panic attacks, impaired cognition, because you don't know if it was tainted. Things like spice or, the K2, like I mentioned before, it's not going to show up in your UDS. So this is something you'd have to go and ask the lab for um, uh, a specific test for to see if this was something that the patient has in their system, aside from cannabis.
Great. Well, this has been a fabulous presentation. Did anyone have any last question that you wanted to ask? You can go ahead and just unmute yourself and go ahead and ask while we're still here.
Yes, this is Jolene. In the Prime for Life group, the neurotransmitter antagonist was introduced to me. Could you speak about that as THC acting like an antagonist where it goes in and binds the site?
So, what are you referring to as far as a neurotransmitter antagonist?
So,
What is it antagonizing?
well, so they describe it as like the natural neurotransmitters that our body naturally produces, and then explained how alcohol and other substance use or substances go in and act like that neurotransmitter, but then the synapse kind of shuts down. And they described THC as being like an antagonist that goes in and binds the site like a key in a keyhole, and it doesn't let the information in and it doesn't let information out. So it just acts like that antagonist they described. And I have not been educated or know more about that in a long time. So I've been curious what the
Okay.
new information is, or what if you know anything about that.
So, as far as it acting as an antagonist, I can tell you where it acts on. So, this also plays into, the hyperemesis syndrome and those causes of those cannabinoidal receptors being overstimulated. So, we're talking about 5-HT2, dopamine. Are those receptors you're referring to?
Yes, yeah,
Okay, so yes, so overstimulation can cause, dysregulation of the production of those. This is why someone will come to you and saying now they're feeling really depressed or they're feeling really anxious. And, that could be a main reason why, because of their chronic marijuana use, because of the receptors that it's hitting or acting like. So overstimulated, hitting the D2 receptors, 5-HT receptors, so things like that. And we all know what treats those things, the antipsychotics or antidepressants. And that's how we go ahead and try to um, reverse, for lack of a better word, or try to um, encourage natural production of those receptors, of course, while stopping the cannabis use.
great. Thank you.
Mhm.
Any other last minute questions that you're dying to ask while we're still on today? If not, I think this is a great place to end. Yafe, thank you so much for your preparation and the knowledge that you brought today. This has been a fascinating topic, and I want to remind everyone who's still on, we are going to have a part two to this where we're going to cover a little bit more in depth those psychedelics that we kind of touched on. So Don't miss that. That's going to be in 2 weeks on the 28th. Mark your calendars. We're going to meet at the same time. In fact, if you attended today, you've already got the link. We're going to use the same Zoom link. So don't worry about re-registering or anything like that. If you do see an email, you can mark your calendar. But if you've already registered for part one, you are registered for part two.
I think I'm
I,
gonna need some credits too. Some
yes,
CEUs.
right? Yeah, definitely. Thank you so much, Yafe. This has been a very fascinating topic. And I think you've not only helped educate us, but it's kind of opened up, some new thoughts as well, in terms
Yeah,
of
wait
like
till we get to psychedelics.
what
Yeah,
these can do and
yeah.
the pluses, the minuses, and the pros and cons. So fascinating.
I appreciate the invite. Thank you so much, Joseph, for having me here. And thank you, everybody, for spending the last hour with me. I appreciate everyone and for your questions as well.